So, Assalamu alaikum everyone. A very warm welcome in today's MRCOG Part 2 trial class. And if you ever felt that early pregnancy questions are confusing or, having some, difficulty, that remember that today's session is for you. So over the next hour, we will simplify these guidelines and we will particularly focus on examiner favorite areas. And definitely we will learn how to confidently solve exam based SBAs and EMQ questions, right? So before this, we start today's class. Let me know who is going to appear in January 2027 exam. And also let me know among the participants who is going to attempt this exam second time. So it will, will be good if I will have idea about the nature or variety of my audience. So please write in chat box your country name and your attempt as well. Okay. Hurry up, quick. So if my audience is mature enough, then definitely I will not focus on, very basic things. It's very important. Yes. So first time, iPhone says first time, everyone is appearing first time in January 2027. And Asma is from Egypt and Farzana is waiting for the result. Okay, good luck for your result, Farzana. So before starting this module, inshallah, iPhone is from Nigeria. Wow, variety of countries today. Okay, so I want to give you people an overview. Specifically, this overview is for the beginners who are going to attempt this exam first time in this January. Okay, so just imagine you are somewhere in your early pregnancy assessment unit. Okay, here you are. So just stay with me and see variety of complaints and diagnoses which you are going to see in your OPD today. Okay, so maybe few patients will come with uh, obviously this is, if I am saying this is early pregnancy unit, so everyone is coming with positive UPT, definitely, are coming up with missing of cycles, are coming with some complaint like with positive pregnancy, bleeding, cramps, right? So we are having that kind of patients today in our OPD. This is our OPD today. So maybe on evaluation, we will see that few patients we will categorize having intrauterine pregnancy, right? And those who are having intrauterine pregnancy, we can still see that like many will, inshallah, many will, will be having normal, viable intrauterine pregnancy, right? But few may be having non-viable, right? And maybe very few patients will belong from that category who will not, for whom we can't say that they are having normal, perfect intrauterine pregnancy, are having non-viable, which we will use to say missed miscarriage. Okay, so if patient is having intrauterine pregnancy but not falling in in that category having viable intrauterine pregnancy, or he is not falling into this where we confirmed her that she is having non-viable or having missed miscarriage. So still we can have few patients who are midway between them, and they will be having intrauterine pregnancy, we know the location, right? This is not unknown location, but about the viability, we are uncertain, right? So in today's OPD, we are going to see a lot of patients who are, having confirmed intrauterine pregnancy, having, viable pregnancy with positive fetal heart rate, everything is okay. They are, and majority patients we will see like this, but very few will come, that today will be, their bad day, unlucky day, and we will break a bad news for them that they are having non-viable pregnancy or miscarriage. And for few patients, some things will be, in midway. We are not very sure that how pregnancy will behave in future, whether it will survive or not, whether that pregnancy, which is, we know the location and it is intrauterine, but maybe in future it will end into a miscarriage or end into a viable pregnancy. So right now at this point, at this timeline, we are, uncertain. So we will say that this is intrauterine pregnancy, but viability is uncertain. Okay. So this is our OPD, and we have seen a lot of cases on single intrauterine pregnancy. Some few are having viable, few are having non-viable, and few are having uncertain. Maybe today we will see another variety. And their patient will say that our UPT is positive, we have missed our cycle. And when we will do their scan, we will not, look at any sag, neither intrauterine, neither extrauterine. So we will say that this type of patients, we will diagnose them at this timeline, they are having pregnancy of unknown location, because we can't say where is the pregnancy, but as their UPT is positive, pregnancy test is positive, so they are pregnant, but we don't know the location. Maybe in future few will be, and into a normal intrauterine pregnancy. Maybe few will end as, miscarriage, or maybe few will end as ectopic. Okay. So at this timeline, we don't know the location. So we will say that this is pregnancy of unknown location. And as we can't say anything right now, it can end into three type of different things like intrauterine pregnancy, miscarriage, or ectopic. So we will, by default, we will look at her as being ectopic. Okay, until prove otherwise. If they are not giving us any β-hCG value. However, if they are giving us β-hCG value and β-hCG is rising, then we will say no. It is likely going to be intrauterine pregnancy, because β-hCG is doubling. But if β-hCG is falling, dropping as and like the failed pregnancy drop means more than 50% they are dropping on second β-hCG value. So we will say this pregnancy is going to be miscarriage. And if β-hCG value is suboptimal, neither perfectly rising, neither dropping perfectly like miscarriage, we will say that this is ectopic pregnancy. Okay. So at this timeline, UPT is positive, we can't say anything about the location. So this is virus pregnancy of unknown location, but the trend of β-hCG will guide us that it is going to be likely intrauterine, going to be likely miscarriage, are going to be likely ectopic. And remember, students, this is your past defining concept. If you can't say anything, then for sure do not label her as IUP, neither label her as, non-viable. Always give benefit of doubt and treat her as ectopic, possible ectopic. Okay. This is very important concept. If your β-hCG is suboptimal or not provided at all, this is for us ectopic. Okay. So in today's OPD, we have seen a lot of patients. Few are having intrauterine pregnancy, few are having pregnancy of unknown location. But maybe few patients will come and their UPT will be positive, and they will say that like they are having excessive nausea and vomiting. So what we will do, we will say that like they're pregnant, so we will label them that they are having nausea and vomiting because of pregnancy. And when we will do their ultrasound, maybe we will see twin pregnancies, and maybe we will see molar pregnancies. Maybe it will be a perfect intrauterine pregnancy. But for sure, if patient is coming in our OPD with complaint of nausea and vomiting, it's not ectopic, it's not miscarriage. Because pregnancy hormones, if are okay, are more okay and are more abnormal, then it will end into abnormal pregnancy, like molar pregnancy. And if they are having twin or single, and because of certain risk factors are having earlier, they're having in previous pregnancies excessive nausea and vomiting, still they can have this. But for sure, a patient who is having non-viable pregnancy or dead placenta, we can't see any symptom like this. He will say that she's having excessive nausea, vomiting. This is very logical thing. Okay. Okay. And so in today's ugly pregnancy OPD, we have seen intrauterine pregnancy situations. We have seen PUL situations. We have seen few patients are coming with excessive nausea and vomiting, and later we found that they are having molar pregnancy or having twin pregnancy, right? Maybe today we will see few patients who are having UPT positive, and when we will see on scan, they are having no intrauterine pregnancy, but having extrauterine pregnancy. So we will say that this is, ectopic pregnancy. Okay. And, depending on the location, if the ectopic inside the tube, this is tubal ectopic, or it's not inside the tube, like it's in, cesarean scar site, or inside the cervix, or in ovary, or in abdomen, even it can be into the liver as well. It is non-tubal ectopic. Okay. So see, in OPD, we are going to see a lot of cases. So this is, short introduction of early pregnancy unit. Okay. So a doctor who is, totally blind, who don't know how to, proceed, I'm giving that blind doctor eyes today, how to look at each case. Okay. So first of all, we will start from PUL, right? PUL means it can end into intrauterine pregnancy, depending on the β-hCG. If it is doubling or increasing, it can end into a non-viable pregnancy. We say that it is a miscarriage, or it will end into ectopic pregnancy. And if it is intrauterine pregnancy, then it can be having normal viable pregnancy, or can have non-viable, or can have uncertain viability, as I already told you. And maybe if the pregnancy is confirmed non-viable, we will say this is miscarriage. With miscarriage, he can steal another diagnosis, which is recurrent miscarriage. If it is first time, then we will say this is a saprotic miscarriage. If the patient who is having viable or non-viable, any type of intrauterine pregnancy can be septic. But septic miscarriage, it's not necessary that FCA should be absent. You will see in your OPD. I am not saying you will see. I wish you never see that patient, but it can come. Like you will do the TVS and you will see the FCA is positive, and still you will see that systemic inflammatory markers are high, and you will say this is a septic miscarriage. Just like the chorionitis, a patient is having coming at term pregnancy, having viable fetus, perfect fetal heart rate, but can develop chorionitis. So chorionitis, or whether it is septic miscarriage, it has nothing to do about the viability, about the FCA. Trust me. Okay. So those patients who, light of patients we have seen in OPD, but few patients can, they know that they are having missed miscarriage, and they will opt as by their own choice that they need no intervention. And we manage them as, case of expectant management if they follow the, criteria, means they are not very high risk, not bleeding, not having any, sepsis. We can manage them. So nature will expel the products of conception by itself, and uterus will be empty. Okay. and we can watch them for 2 weeks. We can give them fair, trial of 2 weeks, and within these 2 weeks, the uterus will naturally expel this, just like the dead baby. Okay. Maybe few patients be do not opt expectant management. They know they are having intrauterine pregnancy, but at their CRL and the sac size is fulfilling the criteria of missed miscarriage, and after uh, breaking that bad news, they are opting the management as medical management. Maybe we provide them some drugs so that they can the process of abortion can start. Our few patients will opt surgical, or by default they are high risk, and we offer them only the surgical is better for them, right? So this is the way you will look today uh, during your OPD. Okay, maybe we can divide miscarriage about the pet type. Means it can be recurrent, it can be saprodic, it can be consecutive, right? It can be missed. Okay, and how it can be septic, it can be threatened. And if we have to manage the miscarriage, then we will divide it in 3 types. Either we will manage them as expectant care, or as medical, or as surgical. So you will see a lot of type of miscarriage, but depend on the intention. Management, if our intention is to manage the miscarriage, then we will face these 3 types of miscarriages: expectant, medical, and surgical. And independent diagnosis we can make with pattern of miscarriage. Like if it is happening 2 or 3 times, we will say this is recurrent. If it is happening first time, we will, and not following the pattern of recurrent, we will say this is saprodic. If it is, they are coming consecutively one by one, we will say they are consecutive miscarriages. Okay, if patient is having intrauterine pregnancy before 24 weeks and having sepsis features, we will say this is septic miscarriage. If patient is having intrauterine pregnancy and she is bleeding, we will say this is threatened miscarriage, isn't it? And maybe patient can come with us with complaint of inevitable miscarriage. Inevitable miscarriage means os will open, and incomplete miscarriage means few products of conception has been expelled and few yet are inside the cavity, and os is still open, patient is still bleeding, endometrial thickness is more than 15 mm, so it's incomplete miscarriage. And if patient is having no symptom of bleeding and os is closed and on scan there is endometrial thickness less than 15, we will say this is confirmed complete miscarriage. Okay, so I have given you eyes how to diagnose various type of patient in early pregnancy unit, and you can see a lot of diagnoses today. 50 approximately 50 different diagnoses you can make today. Okay, so after this introduction, we are going to start our topic. Okay, so right, we have done ectopic, tubal, non-tubal, a lot of bad things today. So my aim today will be to teach you people about miscarriages, about normal intrauterine pregnancies, and about ectopic pregnancies. Right? I will not touch today molar and hyperemesis gravidarum. Okay, we will do it tomorrow. Okay. So I don't think I don't feel myself comfortable, to take 4 5 hour, long marathon session and to, because of my ease, I will be comfortable to wind up everything at one sitting. I will not place you people into, miserable condition. And I know because after 2 hours, your brain receptor will be pre-saturated, super saturated. So that's why we will in our course you will not see such marathon sessions, and our live sessions will be topic wise, 1 or 2 topic, that's it, as per the schedule. Okay, so maybe for early pregnancy we will conduct 3 to 4 live sessions, and this is a short module, we can easily complete it in a week. Okay, so to complete early pregnancy, we will read Ectopic Pregnancy, Miscarriage Diagnosis and Initial Management from NICE. It has been published in 2023. And also we will touch Green-top Guideline, but it is an older guideline. I will advise you, uh, you know, I know Green-top Guideline has, weightage over NICE. But here when you will open your GTG, your GTG, the reference of GTG you will see is miscarriage guideline, which has been published in 2011. And NICE has been updated, and we have already very new guideline of 2023. So it's mean following the Green-top guideline, which is in itself following the NICE, which is older, 2011. So it's not wise to follow the Green-top guideline. But why we have to follow the Green-top guideline? For non-tubal ectopic pregnancies. Okay, because non-tubal ectopic pregnancies are not addressed in this guideline. But is non-tubal ectopic pregnancies like cesarean scar, cervical, ovarian ectopics. Okay. Okay, so so we will do NICE guideline, and NICE will cover 90% of ectopic and miscarriages situations, and even how to treat miscarriage. But it will not guide us how to treat that miscarriage who patient done with by her own intention, because we don't say that this is a miscarriage. We say that okay. Sorry for this unexpected network error, and I'm going to connect it soon. Okay. Okay, students. So, I told you that NICE has wonderfully compiled surgical miscarriages as well, but specifically for MVA, for additional information, we will do this TOG article, and only one table is needed. Only one table. That's it. For one table, we have do this 2015 MBA because they have given question from this table. Okay, I will see you. I will show you. And for abortion care, those miscarriages which patient actually opt, and basically it's a healthy intrauterine pregnancy, live baby, and by her own actually willingness, patient opted to miscarry. We say that it's an abortion, and in abortion care guideline care, we follow the NICE guideline, which has been updated in May 2025. So far, how to treat miscarriages, the most recent guideline is that guideline, which is, published in 2025. And why I am, emphasizing here, because this guideline has changed the, recommendation of giving NTD. Okay. And that is the latest one. Earlier guidelines like 2011, GTG, 2023, everyone have mentioned that if you are, managing your patient on surgical grounds, you have to give NTD irrespective of the gestational age. But this guideline, which is so far most updated and recent, this guideline said whether it's abortion or any surgical miscarriage, if patient is non-immune and before 12 weeks her gestational age, do not give NTD. Okay, so that's why doing this guideline is important, and knowing about this guideline is also very important. Okay, now I told you people that non-tubal ectopic pregnancies we will cover from the Green-top guideline, but a few tables from abdominal pregnancy talk, early and advanced, we will do these two articles. That's it. So if you are skipping it, it's okay perfectly. But if you are doing that one table because a question has the income from this table, so we will do it. And then about this most important talk, this is cesarean scar ectopic pregnancy. Although it's an older talk, and we said that we will do the recent talks and are those talks which has been released in 2000 in last 3 years, but still we have to do that older talk because college love that talk article. If you are not reading that talk article, you can't actually solve your MRCOG part 2. A lot of EMQs and SPAs. Trust me, you will. This talk will guide you when you have to give local metho, when you have to give systemic metho, when you have to how to treat type 1 and type 2 ectopic. Okay, so this is important. So before moving forward in your exam, approximately 8 to 10 questions are coming up from this module. And I know the type of question as well. Trust me, every time they judge you on these concepts. They will change the question, I agree. But how they can change the concept? They will every time they will, test you about acute abdomen. And this acute abdomen can be because of UTI, can be because of ectopic pregnancy, and can be because of ovarian hyperstimulation syndrome, right? Can be any GIT issue, can be appendix. Okay, so 1 or 2 EMQ definitely you will see from this concept. And how you will address this question? You can entertain this question only if right from the start of your preparation, the type of recalls, which type of recalls are coming up from this, right? And what is the pattern of, pain or surgical abdomen? I will show you later. Then one question definitely is coming up from the type of pregnancy, whether it is PUL, whether it is ectopic, whether it is intrauterine. One SBA is students must. Then you will be, and one SBA mandatory must, it will come from, how you will treat tubal ectopic, and it will be very simple to treat, trust me. And I love this question because if you are good in your cramming, you can easily, pick a right option. And then they will test you about the recurrent miscarriage, and it is going to be a, tricky question. Recurrent miscarriage, I will not teach you today because it requires 2 hour whole, dedication so that you can better understand how to treat APLS and thyroid issues and anomalies issues. Okay, but definitely one or two questions are coming up from recurrent miscarriages. Few will be unexplained and few will be with threatened miscarriage and still with recurrent miscarriages, and so a lot of overlap between low-prene and progesterone and even IVF. Okay, and one or two questions are coming up from hyperemesis gravidarum. I love these type of questions. They are very straightforward. You just have to know the peak scoring, or you just have to know the red flag. When you have to admit patient by any means, whatever is the peak score, into the ward. And second SBA will be on to the on how you will treat, like first line, second line, and third line, right? That's very easy, and molar is also very easy. Do not do it, very deep. Every time they ask about the incidences, about the FIGO scorings, about the difference between GTD and GT, and that's it. Okay, so approximately 8 to 10 questions are coming up from this module. Okay, so moving forward, I told you people that they will judge you. 1 and 2 very precious MCQs and EMQs are coming up from acute abdomen, and this guideline will not entertain it because it will just entertain threatened miscarriage for pain or ectopic. That's it. But in MQ you will see a lot of options, like you have to exclude appendicitis, UTI, and OHSS, torsion, etc. So it's very simple. Okay, in appendicitis they will say you that it will be severe right side ilicosa pain, and patient will be having fever, nausea, vomiting. Okay, increased inflammatory markers. Ultrasound they will give you some hint that patient is having some pouch which is blind ending or 6 centimeter tubular mass, and at the same time her cycle will be regular, or she will be 2 or 3 it will be her second or third day of cycle. So it's mean ectopic has been ruled out. So you will confidently say this is appendicitis. Okay, and if it is UTI, obviously you will see dysuria, right? Positive urine dipstick. So it's very easy. And if it will be OHSS, then they will definitely give you that she has taken ART recently, and her pain is not actually dramatic. It's very, predictable, sudden, and gradual. With nausea and vomiting, with positive pregnancy or no pregnancy, you can easily make sense because of these buzzwords. But if it is torsion, that it will be a dramatic presentation. Patient will have, on nights he will suddenly wake up out of nowhere because of pain, and maybe they will give you some clues that she is having a cyst as well on follow-up. So because of its sudden and a dramatic presentation, you can easily make the diagnosis of torsion. Okay. Because we know that if it is UTI, then there will be dysuria. If it is appendicitis, then there will be inflammatory markers, and cycle will be regular, and there will be no cyst, and they will be gardening and psoas sign positive or tubular pouch. And if it is torsion, then she will wake up at night. Okay, and many time only the key will be torsion, 90%. And 10% the key will be OHSS. Less likely it will be UTI and appendicitis. Okay. Because if it is appendicitis and UTI and all buzzword, then this is a very low yield question, and they don't give any low yield question. As because this is gyne-obs exam, so definitely 90% question option will be OHS or the torsion. Okay. Then rupture ectopic comes among 90%. Sudden sharp pain, and will be missing her cycle. And by default, if patient is missing her cycle, almost this is ovarian cyst. Ectopic pregnancy. And it can be ruptured ovarian cyst as well. Okay, it can be hemorrhagic cyst as well, and it can be PID. PID is very, very easy. They will never give this option because here you will see fever, vaginal discharge, some intervention. You can easily pick. Any blind person can pick this diagnosis. One thing is important that PID also has the cervical excitation and ectopic pregnancy also has cervical excitation, but PID don't have, it will not come like that she is missing her cycle. Okay. A ruptured ovarian cyst less likely to come. Hemorrhagic can come. And with this, they will give you, ultrasound buzz, that web-like pattern or lace-like pattern. And pain will not be that much dramatic like the torsion. It will be sudden, unilateral, and maybe with some pain management, it will settle down. But you will obviously keep her on follow-up, and after 6 weeks, you will again call her. And if it is severe, you will open her this, okay? So if you know these tables, you can easily pick correct option in your exam, in your EMQ, okay? So just check this question. A woman presents after recollection with abdominal pain and sense of fullness, in abdominal pain and vomiting. What is most likely diagnosis? So, what they are giving you hints that recollection, ART, and distension with mild pain and vomiting. This is not torsion picture. This is not ruptured cyst picture. Neither it is appendicitis picture. Neither it is any early intrauterine pregnancy picture. Why a patient with having normal pregnancy will come with this? Okay, so this is very simple. This is OHSS. You people are very right and logical. Okay, so these are few actually slides just for your own interest. So how you can calculate various gestational ages if they are giving you the CRL, okay, in early pregnancy CRL and SAG. It will help you somewhere in your practice. That's it. Otherwise, NICE and GTG have not told this. I have taken it from Radiopedia, and you somewhere definitely you have to use these measurements. So learn some basic calculation. This is $1 million gift, trust me. And in recent exam, they have tested it. A question has been come, and they have, provided 3 β-hCG values, and you have to, and it was a ectopic pregnancy scenario, and you have to see that after metho, the trend of β-hCG, whether it is on day 4 and between day 4 and 7, it is dropping more than 15% or increasing. So whether it is pregnancy of unknown location, where you have to check the trend of β-hCG, whether it is rising 66% or not, or dropping more than 50% or not, or it's a scenario of ectopic pregnancy with expectant management, or medical management, you must have to do these calculations, and it becomes quite difficult if you have not worked on it in your preparation. So cram this. If they say you, if the scenario is on PUL, and you have to actually interpret β-hCG values, so you will see, okay, they have given you like first value, which is let's assume 200, and second value, which is 400. Okay, so basically you will multiply the first value with 1.66, and after multiplication, whatever is the answer, if the given answer and the second value, okay, if the second value is more than this, the given answer, then it's mean it is rising more than 66%, isn't it? So you will say this is intrauterine pregnancy likely. Like I have given you 2 values that the patient in your OPD patient you have seen is having only UPT positive, and there is no intrauterine or extrauterine pregnancy. So definitely you will put her on PUL algorithm, and you will see her β-hCG 2 values which have been taken 48 hours apart. So how you will calculate? You will see what is the first value. You will multiply it by 1.6%. And if the outcome, whatever is the outcome, and like, but this is 200, okay, 400. So this outcome and this outcome you will compare. Okay, so let's you want that it should be 300, and your outcome is 400. So it means it's rising more than 66%. Many candidates actually in their preparation do not work on these calculations, and in exam they feel very face very difficulty. So always pick the first value and use it for multiplication or division, and compare the outcome with the second value. Okay, this is the this is the $1 million tip. So in our exam, we have to actually see 66%, and for metho, we have to see if it is dropping 15% or not. So you just have to multiply the original value or the first value, or you can say day 4 value with 0.85. That's it. And if the outcome and the result, you will compare, and you can easily decide it is dropping or not, and falling or not, and you can take the decision of giving second dose of metho or not easily. And in PUL, you will see that if it is dropping more than 50%, then you will not keep her own β-hCG follow-up. You will advise her simply come after 1 or 2 weeks for UPT. That's it, because this is likely a non-viable pregnancy. And how you will say confidently, because the first value of which they have given you, you have multiplied it by 0.5. And if the outcome is you will compare with the second value, and second value is dropping more than this. So it means it is dropping more than 50%. Okay, is that clear? You just have to remember these 3 calculations. If you have to check it is rising 66% or not, pick the first value and multiply it with 1.66. And in your exam, you have calculator built in, provided on your monitor. You can easily do that calculation easily by using remembering these formulas. Okay, if we have to check the fall of 15%, multiply original value by 0.85, and if you have to check the drop 50%, multiply it 0.5. That's it. Okay, and you can practice them as well. I have share some values. Okay, so check this question: a woman undergoing expectant management for ectopic pregnancy. Ectopic pregnancy expectant management, and we have day 2, 4, and 7 values. So what we will do, if you have not worked on these calculations, you stand nowhere actually, unfortunately. Okay, so quickly solve this for me. I have shared you the trick as well. Waiting for your response. Hurry up, write in chat box what we should do. Day 4 value is 670, and day 7 value is 515. Obviously it is dropping. Is it dropping more than 15% or not? Then what we will do, we will multiply it by 0.85, and the outcome is 569. Okay, and here it is 515. So it's fall of 15%, right? No, it's not falling, basically. It's not falling. How it is falling? It should be 569, and it's only 515. Take your time. Yes, I'm doing my calculation. You should do your calculations and let me know. Forget about the mention key. Okay. Actually, the 569 is okay. It is more than 15% fall, and you have to continue the weekly serum β-hCG. Okay, because it is more than 15%. It is higher, it is lower. So it's mean day 7 value has been, dropped more drop now here. If it was, for example, day 7 value will be, what I will say, somewhere 570, then it will be, mess. We are happy with this drop, okay? It is 22% fall, you are right. 22 or 23% fall in my laptop. So option B is okay. See how these calculations will save you. If you have not worked during preparation on these calculations, trust me, in exam you will be clueless. And this is your recent exam question as well. Okay. So now don't worry. When C will be correct? When okay, when the when day 7 value will not drop more than 15%. It will drop less than 15%. Then we will not keep that patient on expectant care. Then we will re-evaluate her, discuss her all options like medical and surgical, and for sure it will not be expectant. Then we will, maybe she opt, and she can easily opt because the before 5,000, and if SAC is less than 3.5, we can discuss me as well. Okay. So it is 515, and more will be like if it is 200. The more it will drop, then the more it is okay. We are happy, but by any mean, it should be less than 569, and it is less than 569 because it is 515. 515 is more good because it is less than 569. Okay, it's dropping less than 15%, and in our case, it has been dropped up to 23% rather. It's good thing. Why we should give her, we do any intervention? We will definitely continue our expectant management. Okay, so girls, you will be, you will think we have not done any guideline so far. We are doing the guidelines. All the listed guidelines which I have shown you that we will do, we have covered them. Like in ectopic pregnancy, how to, plan various managements and how to calculate, we are doing it. But my way of teaching is not like that. I will open the Green-top guideline nice and start reading and, like a report. I don't do this. But by the end of my session, trust me, above mentioned, all resources will be fully covered. When you will start solving questions, you can it can make sense easily. And when you will read it, you actually will feel that you have heard somewhere that these things. Just trust me and keep following me. So though it look odd that I am again covering the basic things, and this is uh, exit exam, and I am covering your medical school level things, but it's not. Trust me, do these guidelines for me. So what is a miscarriage? Spontaneous loss of pregnancy before fetus reach viability, means before 24 completed weeks of gestation. Okay, so this is simple definition of miscarriage. What is saprotic miscarriage? Saprotic miscarriage, isolated, non-recurrent loss. And maximum saprotic miscarriages, if they are, first trimester miscarriages, means before 14 weeks, 90% their cause usually is, random fetal chromosomal abnormality. What is the first trimester miscarriage? Loss occurring in the first 13 weeks, or 13 plus 6 till 13 plus 6 weeks, or before 14 plus 0 weeks. This is first trimester miscarriage. What about the second trimester miscarriage? Loss occurring from 14 plus 0 up to 24 plus 0. This is second trimester miscarriage. Okay. more specifically 23 plus 6 are before 24. You can't include 24. If the moment it will touch 24 plus 0, then it will not be a miscarriage. Then it will be a labor, birth, or preterm labor, something like that. Or intrauterine demise. Okay. What is pregnancy of unknown location? Positive pregnancy test, but no intrauterine or extrauterine pregnancy seen on scan. Okay. And what is pregnancy of uncertain location? You know the location. It is intrauterine, but the mean sac diameter is less than 25, or CRL, which we say fetal pole as well, it is less than 7 mm. So at this threshold, we will say that viability is uncertain. But if the threshold has achieved, like SAC is 25 or more than 25, and CRL is 7 or more than 7, and on repeat are done by, confirmed by senior at the same time, okay? At the same time, like you have seen that SAC size is 25, and you are not sure, and you called your senior, and he told you that you are right, then there and then this is miscarriage. It's okay, you can discuss management option with her easily, okay? Or if no senior available, our senior also feels that he is not sure, you can advise her to come after 7 days for TVS or 14 days after TAS, okay? So if the same value on second scan, then this is confirmed missed miscarriage or non-viable pregnancy, okay? So again, many students do mistake here. In their mind, this is by default that if, SAC or CRL size is after threshold, which is 25 and 7, they must have to call her after 1 week for second TBS. No. If there and then senior confirmed that this is a miscarriage, at the same day, this is missed miscarriage. Okay? Now open your guideline and see that difference, because I believe 90% have not noticed that point in that way. My voice is not clear. Who is facing this issue? Amreen? And if my voice is not clear, write in chat box. Any other person? Takwa says it's clear. So if anyone can hear me clearly, it's mean problem is not at my side for sure. Okay, logical thing. Okay, so we have seen that PUL means unknown location and PUV means uncertain viability. Okay, don't mix them. Then about the definition of recurrent miscarriages, we already know that if patient is having 3 or more than 3 first trimester miscarriages, or 1 or more than 1 second trimester miscarriage, we say that she is a case of recurrent miscarriage as per our Green-top guideline, which has been published in 2023. Okay, so important thing is that which you do not have to miss, that for recurrent miscarriages, it's not important that they should be consecutive as well. Okay, and it's not required to be with the same partner, because certain maternal pathologies are not partner related, like APLS, uterine anomalies. Also, if patient is having 1 or more than 1 second trimester loss, she is having recurrent miscarriages. She is fulfilling the criteria of recurrent miscarriage if it is happening in second trimester. But if it is happening in first trimester, then it should be 3 and more than 3. However, if patient is having, established risk factors, then we can consider to investigate even after 2 losses as per 2023 guideline. Okay? Like we know that she is already having diagnosis of APLS, or her age is more than 35, so many things. If with established risk factors are having already diagnosed case of thyroid, uterine anomaly, then we after, if you are suspecting anything, that she can have thyroid, she can have APLS, the risk factors are very obvious, then we can plan to investigate even after 2 losses. And one question is coming up from here. You will see a patient who is age is 39, obese, and she's having 2 recurrent miscarriages, and third is going to happen. So what you will do? Obviously, we will investigate because we will consider it high risk. Okay. So in previous guideline of recurrent miscarriages, it was like this, that recurrent miscarriages should be consecutive. Okay, but in 2023 they have removed it being consecutive. It means that patient have 1 miscarriage, then 1 live birth, then second miscarriage, then 1 live birth, then third miscarriage. So total 3 miscarriages, somewhere live births as well. Still, we will say that she's having diagnosis of recurrent miscarriage. Okay. Now, I will say you that Americans and Asher guidelines are different. You can skip it because obviously you are going to make your key as per the GTG. But when you will use various AI tools and Google, then you will see a lot of confusion because they will refer these guidelines as well. So don't do this. Okay, consecutive miscarriages means loss occurring one after another with no intervening pregnancy progression behind the miscarriage threshold. Means no live pregnancies or any pregnancy after 24 weeks. Non-consecutive means loss is separated by live birth or other pregnancy outcome. Okay, as I told you in like the recent DJTG also say that recurrent miscarriages can be non-consecutive as well. Okay, clear? So far, any issue? See, these definitions are that much important. I'm sure many of you don't know about this. Okay, so what about the primary recurrent miscarriage? Recurrent miscarriage in a woman who has never had a live birth. You have to answer in front of examiner in your OSCE such definitions. Okay. Secondary recurrent miscarriages means she is having 1 or previous live birth earlier. Unexplained means no cause find. Okay. What is pregnancy loss and leave the pregnancy loss, but do the biochemical loss. Biochemical loss means very early loss identified only by transient positive urine or serum β-hCG before the pregnancy is ever visible on ultrasound. So we will say that is a biochemical loss. What is aneuploid miscarriage? And it is very important. If you have good concept here, there is one question in your recall as well. Okay, so aneuploid miscarriage means pregnancy with an abnormal chromosome number like trisomy, monosomy, polyploidy, and commonest cause also of saprotic miscarriages. Okay. What about the euploid miscarriage? Like if a patient is coming, a patient ABC is coming in our OPD today, and she is having 3 recurrent miscarriages. And as most common cause of recurrent miscarriages are even saprotic miscarriages, in first trimester is chromosome. We have send her. If we have her fetal products, we have send them for karyotyping or cytogenetic analysis, and we receive that the baby is having euploid miscarriage. So it's mean this is not chromosomal issue. We will check her antibodies for APLS, for thyroid, and we'll proceed expand our investigation, because we know that pregnancy with normal chromosome complement means that the somewhere issue is in the persistent maternal or the anatomical pathology. So you will there will question a patient is aging 36 and coming with recurrent miscarriages, and on her karyotype shows that she is having euploid. So if you know what is euploid, then you will see a lot of options like genetic counseling, send her for genetic counseling. Second will be APLS workup with thyroid. So definitely you will not send her for genetic workup because they have sent that is a euploid miscarriage. You will work on maternal factors, means APLS first and thyroid. Okay, clear? But if it is a recurrent miscarriages and it is a a patient is having trisomy, and trisomies are most common, you will not refer her for certain maternal factors. You will first send her towards genetic counselor. He will discuss her that you cause in your case is these trisomies, and these trisomies he will check the pattern as well. These are unbalanced. So why they are unbalanced? He will check mother and father both, not any, both. And if anyone having balanced translocations means they are the they are the reason of this recurrent miscarriages. Case solved there and then. Okay, case solved there and then. Okay. So now few more basic definitions. Threatened miscarriage means bleeding before 24 weeks, pose closed, pregnancy continues, viable intrauterine pregnancy with fetal heart rate, and we don't need any other thing for this. Okay. Inevitable bleeding, pain, os open, POC is not yet passed. Okay, incomplete, partial passage, still bleeding, os open, and thickness is equal or more than 15. Complete, full passage, os closed, patient asymptomatic, thickness less than 15. Missed miscarriage, missed miscarriage, patient can be asymptomatic. Incidentally, you will see these values. Our patient will come with spotting, brown discharge, or she will come that she is no more feeling nausea and vomiting, and pregnancy symptoms has been vanished. Okay, so miscarriage can be totally asymptomatic as well on timeline if it is early. Okay, so now this is $1,000,000 question. Think about this patient in your OPD. You are R4 trainee and ST5, and you have been asked to review a 39-year-old patient who has presented with some pelvic cramps, bleeding, and it's her third miscarriage. She declined TVS, and you have done her TES. And TES, you have seen that sac measuring 6 mm, only no fetal pole. So what's coming up in your mind? Tell me one by one. How many problems she has and how you will manage her. What will be her, one line management? Think about it. Okay, I'm waiting. Write in chat box. 39. Okay. Next risk factor. Quick. Okay, Takwa, I got it. Age. What else? Threatened miscarriage, isn't it? Because she is bleeding. She is bleeding. She's having cramps. Hmm? And third one, she's having recurrent miscarriages because of her risk factors. It's her third miscarriage. History of third, okay. A history of 3 miscarriages. So by default, recurrent miscarriages as well. So we are having so many issues. Recurrent miscarriages 1, threatened miscarriages 2, age 4. 4 means pregnancy, intrauterine or extrauterine? Intrauterine pregnancy. And what type of intrauterine? Uncertain. Okay. So you will consider she need workup or not? Right now she's having uncertain viability pregnancy. Takwa, why what β-hCG will do? This is already confirmed intrauterine pregnancy of uncertain viability. For uncertain viability, we repeat scan. We don't do β-hCG. So one thing we will do that we will do her TVS after 1 week. Okay. What else she need? She is having recurrent miscarriages. Obviously, like this is what we will suggest do her karyotype of her and her partner. Okay. Number 3, APLS, TSH, antibodies, peroxidase, okay? And number 4, what we will say? We will discuss with her progesterone because this is a threatened miscarriage with previous miscarriage. So any management who is, having this, call her after 1 week, right? No, give her progesterone, discuss her, investigations, including APLS and TSH and antibodies. So it will be perfect plan. Okay. By the way, that was your OSCE case. Just to make people, more practical, I have added this. So she's having recurrent miscarriages, threatened miscarriage, intermittent pregnancy, but uncertain viability. For recurrent miscarriages, obviously, we will do workup. For threatened miscarriage and with previous miscarriage, we will prescribe, we will consider progesterone. And we will offer when we can see the FCA positive. As no FCA positive, so that's why we will consider. And for IUP, but uncertain viability, we will request to come after 1 week. That's it. That's it. So upper gestational limit defining miscarriage is 24. Commonest cause of an isolated first trimester miscarriage, random fetal chromosomal abnormalities. And if I will say commonest cause of recurrent first trimester miscarriages, it will be unbalanced translocation because of trisomy. Okay, we will discuss it in recurrent miscarriages, no worries. First trimester miscarriage occurs before 14 plus 0 or up to 13 plus 6. Gestational window for a second trimester miscarriage, 14 before 24 plus 0. Positive test but no intrauterine or extrauterine pregnancy, this is PUL. SAT less than 25, this is pregnancy, intrauterine pregnancy but uncertain viability. So we will repeat scan after 7 days. Fetal pulse CRL 9, no heartbeat, closed O's, likely diagnosis. Likely diagnosis after threshold is missed miscarriage. However, this is only a likely diagnosis. Management is still, we will call her after 1 week. Okay, be careful. They are asking about the likely diagnosis. So likely diagnosis is missed miscarriage, but management is not this. We will start, inducing her with mifepristone. No. Either we will call senior, and if senior says yes, it is yes, then it is missed miscarriage. Or if he is uncertain or no senior, then he will come after 7 days. Okay. Okay. Definition of recurrent miscarriages we already know. 3. They can be non-consecutive, or 2 if established risk factors. Okay. We have done this. Primary, we have done secondary, unexplained, no cause. Okay. Biochemical means no ultrasound or histopathological diagnosis. Aneuploid means trisomies. Euploid means good. Okay. Threatened bleeding. And os open means inevitable. Os open and partial expulsion has been done, incomplete. Endometrial thickness more than 15, incomplete miscarriage. Okay. So read the diagnosis, confirm the diagnosis. 9 weeks pregnant, heavy bleeding, on speculum cervical os is open, but no products have been passed. TVS shows an intact gestational sac, low in the uterine cavity, some sitting within the cervical canal. So as they have not guessed a pass route, so it is inevitable. But if you has been expelled, then it will be incomplete because thickness is more than 15 as well. Okay. Many students face difficulty in diagnosing incomplete and inevitable. That's why. So we have to actually learn some rules now. If you want to take break, I can give you break for 1 minute. After this, we will start. Okay, so here we will take 5-minute break. Yes. And then we will actually do some real things like these. Okay, don't be worried. Don't worry. You will enjoy this. But okay. Any doubt so far in slides which we have covered? Okay, good. So now we will set certain rules. Okay. Today in our OPD, we have seen a patient as well who was having just positive pregnancy test and symptoms of pregnancy. We have covered approximately 15 slides and 15 left. Okay. So what we will do after positive pregnancy test, definitely we will do ultrasound. And if on ultrasound, no intrauterine pregnancy, neither extrauterine. So here at this timeline, we will say this is pregnancy of unknown location. And to check its likely outcome, diagnosis right now at this time is PUL. Okay? And likely diagnosis depend on β-hCG trend. Today we have taken serum β-hCG and we called her after 48 hours and we have done taken her serum β-hCG. So we have two values. Okay. So with her first value, we have multiplied 1.63, and if it is rising more than 63%, so it means likely it is intrauterine because it is rising, say more than 63%. 66% rise is mentioned in TOG article, but TOG article is very old. It was published in 2016, and we have a very nice recent guideline of NICE 2023. So we will follow the 63 rise, not 66 rise. Okay. And if the first value we actually multiplied, because the second value is dropping, so we want to see how much it has dropped. So we will multiply it with 0.85, the first value. And if the outcome is says that drop has been more than 50%, so this is a likely failing pregnancy. Okay. But if it is dropping, neither it is rising the way we want it. So we are somewhere between. It is suboptimal rise or fall. So what is this? This is intermediate condition. So this is ectopic pregnancy. We will immediately refer her within 24 hours to early pregnancy assessment, higher centers for senior review. And they will further, decide the management plan. Okay. If it is likely intrauterine pregnancy, what we will do? We will do her TVS after week or 2 week. That's it. If her second β-hCG was more than 1500, so maybe we can do her TVS earlier than 1 week. That's it. It's mean that a patient who is having UPT positive and diagnosed as PUL, her β-hCG is rising 63%, and the second value was more than 1500, we can do her earlier TVS. Means less than 7 days, right? Otherwise, if it is not more than 1500, we will not do her earlier TVS. We will do her CVS 7 to 14 days. That's it. That's it. If confirm viability, we will say this is okay, fine. But if it is dropping more than 15%, 50% means this is going to be a failing pregnancy, means missed miscarriage. We will counsel her. We will give her PIL, patient leaflet information, and we will just say that go home and repeat her UPT after 2 weeks. That's it. That's it. And UPT positive, come back to us. Negative, okay, fine, stay there. But if meanwhile this you face any bleeding, pain, which is atypical, then you have to come immediately. That's it. Okay. So this is our PUL algorithm. So what we have covered so far, we have like in OPD, we see a patient who is having only UPT positive. We done her TVS. TVS says no intrauterine or extrauterine pregnancy, means it is PUL. we will advise her, we will take her β-hCG, serum β-hCG, and advise her to come after 48 hours. And after 40 hours, we have taken another β-hCG. Both these β-hCG we have, with first β-hCG, we have multiplied with 1.63. And if it is, rising more than 63%, and the second β-hCG is rising more than 63%, as per talk 66, but follow 66, 63, sorry. So it's mean this is intrauterine pregnancy because beta-hCG is rising. Okay. And we will advise her do her TVS of after 1 or 2 weeks or 7 to 14 days. And earlier, if her second beta-hCG, which was actually more than 63% rise as compared to the first one, we can do her TVS earlier as well. Okay. So far, any doubt here? No doubt. Okay. Second situation when her beta-hCG was, dropping more than 50%. This is, a counseling situation. We will break that bad news that it is not going to be a good pregnancy because a good pregnancy should double, but it is dropping more than double. So she should repeat her UPT only after 2 weeks. That's it. But patient is not, our patient belong neither from this category, neither from this category, means suboptimal rise or drop. We will, within 24 hours, we will refer her in early pregnancy assessment unit for senior review. That's it. Yeah. So far, like we have covered PUL various outcomes. Okay. So next is yes, this is key numbers of miscarriages which we have done. But here is some exception, and this exception is that if patient in our OPD is coming today and she is having UPT positive, she is low risk, means no previous ectopic, not smoker, no history of appendectomy, hernia repair, no uterine anomaly, nothing. And her gestational age is less than 16 weeks. So early pregnancy with bleeding, right? And less than 16 weeks. Okay. We will not actually look it as a threat. We will say her go back and repeat her UPT at 10 days. That's it. Because she came here with complaint of bleeding. So if it will, and she's low risk as well. So if maybe it will end into a miscarriage. So her UPT will be negative. Maybe it will become a viable pregnancy, her UPT will be positive. If positive, then she will come to us. And meanwhile, if she have any atypical features, she will also immediately come to us. Okay. So this is an exceptional situation where patient is less than 6 weeks, having PUL, no intrauterine or extrauterine pregnancy on scan. We are doing nothing. We have just advised her to repeat her UPT after 10 days. That's it. So just remember this UPT, somewhere you are doing TVS after 1 week, earlier before 1 week, somewhere you are doing UPT at 2 weeks, and here you are doing UPT at 10 days. So if you are doing it that way, you will not forget in an exam, okay? Otherwise, you will be worried about a lot of UPT days. So here patient less than 6 weeks, bleeding, no pain, no risk factors. We will do nothing. We will manage her as expectant and we will advise her to repeat her UPT at 7 days. Negative miscarriage confirmed, no further action, positive return to us. Any atypical feature immediately come or should report within 24 hours. Okay. However, do not mix this patient who is having, like bleeding and pain and she's low risk and less than 6 weeks with that patient who is having confirmed miscarriage. And by her own choice, she opts for expectant management. Okay, this is a different scenario, but trust me, in exam, both mix up. So I'm covering it side by side. Okay, first slide. That was less than 6 weeks, bleeding, no pain, no risk. Okay. And here it is a confirmed miscarriage. She opt that she will follow expectant management, means no intervention. We will give her written information, pain relief advice, and here we will advise her to wait for 1 or 2 weeks. Within 1 or 2 weeks is if she bleed and symptoms resolve, it's mean it is completed miscarriage, and she will repeat in her home UPT at 3 weeks. And if negative, okay, fine, stay here, but positive, then she will report to us in EPAC. Okay. However, in your exam, there is a question as well in which the patient has opted that she will, and this is a confirmed miscarriage, and after discussion, she want to be treated as, expected care. On expected care program, maximum 2 weeks or 14 days we can give. If within 14 days, she has not started any bleeding, she will come to us and we will do her scan. Or she started bleeding, but she is experiencing still pain, bleeding, which is not settling. Again, she will come to us and we will do the scan. Okay. Here you will see a question in your exam. Patient opted expectant management, 14 days has been passed, and no bleeding has been started. What you will do? In choice, there will be TVS, there will be β-hCG, and a lot of options. So we will do the scan. And maybe she is having incomplete miscarriage, so we will do the scan. Okay. Don't mix it with that expected management where patient was low risk and it was less than 6 weeks. And as it was low risk and she is bleeding, right? More bleeding and no pain. That's why she is low risk. If pain, then it is ectopic until proof otherwise. So if she is bleeding and she is having low risk factors for ectopic, only in that situation, we will offer her that go home and repeat her UPT after 7 days. That's it. Okay. Clear? Okay. So again, revision slide. What is pregnancy of uncertain viability? If we have done TBS or TS, it depends. It will be different duration, but CRL and sac size will be different. Okay, like a patient is having on CRL more than 7 mm or equal to 7 mm CRL, or sac without any visible CRL or pole 25 mm or more than 25 mm. This situation, this is likely a failed pregnancy. But before confirmation, we will seek second opinion. If second opinion says yes, it is confirmed, this is confirmed. Or here they have said and or. This is enough. However, not available, or the second person also think that he is not sure, we will call her to come after 7 days. And if same findings, then this is confirmed miscarriage. We will discuss management options with that patient. Okay. This is about TBS. And if TS, then she will come after 14 days. That's it. And if the SAC and CRL is less than 7 or 25, then this is pregnancy of uncertain viability. If it is touching 7, if it is just touching 25, we are sure, we are actually, we think that this is not uncertainty. We are certain that it is going to be a failed pregnancy. However, for confirmation, we need second opinion or a scan after 7 days. That's it. A scan if we are going to do TS after 14 days. Here sometimes they play a trick. A patient comes and on TS they have actually given the findings that her CRL is 6. So in option, there will be, and the catch point will be that what is the first line management or ideal management. So she has done TES. It doesn't mean if she has done TES, we will do TES again. In option, there will be option TVS after 1 week and TAS after 2 weeks. So ideal is always TVS. Although the first was TAS, but again, after 7 days, we will request her to, go for TVS. Okay? So it will be the first or ideal. However, if in option they said she refused TVS at all, so we will not then opt this choice. Okay? Clear? Clear so far? Girls, boys, let me know.
Yeah, ma'am, can you repeat the TVS, please?
Okay, a patient came in OPD with her TS and TS showing that her CRL is 6. So what is next ideal step? Do her TAS again or do her TBS again? TS after 14 days and TBS after 7 days. So what is ideal? So if she refused TBS, then TS. If they have not mentioned TBS has been refused, then ideal is TBS every time. Okay? Be careful. Her TS has been done somewhere else, but she has been referred to you. And if you have TVS, do TVS. Rather discuss with her TVS is better than TS. Counsel her. But after counseling, if she refused at all, then TS. Okay? Another question in your exam, and it was your 2024, I guess, or July or 2025 or July, but it was July somewhere. The scenario was that TVS showing CRL 7. Okay? What you will do next? What you will do next? It was second opinion. It was this and TVS after 1 week. So what you will do opt? First thing is second opinion. Okay. If second opinion not available or second opinion 2 not sure, then TVS after 1 week. Okay. Another scenario, it is actually older question. It was actually came in 2020-21 somewhere. Here the SAC was 25. Okay. Second opinion taken and second consultant said, yes, it is non-viable. You are suspecting at 25 non-viability. For confirmation, you involve second senior person. He also agree that this is the patient is having, missed miscarriage. So in option, you will discuss her treatment options. Number 2, or you will repeat her TVS after 1 week. So as the second operator who is senior has confirmed that this is missed miscarriage and threshold has already achieved, then don't advise to come after 1 week. There and then discuss treatment option. Okay. So next is ectopic pregnancy. Okay. In ectopic pregnancy, what is ectopic pregnancy? Pregnancy is not inside the uterus, or even if it is inside uterus, it is also another pregnancy in somewhere outside uterus, means heterotropic. Okay. Okay. So how we should manage such kind of pregnancies? Ectopic means extrauterine pregnancy. Extrauterine can be tubal and can be non-tubal. Okay? Tubal we can manage expectant, medical, surgical. Non-tubal, 10% only we can manage as medical, 90% we do surgical. Surgical where? Ideal, like ovarian, ideal surgical, corneal, ideal surgical, interstitial, ideal surgical, cesarean scar, ideal surgical. Okay. However, if cervical ectopic, very early, cesarean scar, very early, and by the way, abdominal two surgical. So medical expectant, very, very rare. Medical only 10%, and only in cervical ectopic, less than 9 weeks gestation, β-hCG less than 10,000, and resolving. Are very early cesarean scar ectopic pregnancy. These are the type of non-tubal which we can manage on medical line. Otherwise, every 90% we have to do surgery. Abdominal we have to do surgery. Ovarian we have to do surgery. Corneal we have to do surgery. Interstitial we have to do surgery. Cesarean scar ectopic, surgery is better overall. But in certain situations, if type 1 very early, we can go with metho as well. And similarly, in ovarian ectopic, when patient refuse surgery, we can opt metho as well. Okay. So primary treatment 90% in non-tubal will be surgery. In every type of ectopic, the first line investigation is TVS. But it's not for that patient who is, having hemodynamic instability. If patient is having hemodynamic instability, TVS or laparotomy. So always laparotomy because she is not stable. Okay. And if she is having hemodynamic stable and she is having acute pain, okay, acute abdomen, and coming on, night, TVS is not available. Don't wait for TVS. Go for laparoscopy. Because I have not mentioned she's hemodynamically unstable. I just added that she's having acute pain. In acute setting, and patient is stable, preferably you have to do laparoscopy, whatever is the TVS. But as a sportive measure, if TVS is available, better to add TVS. That's it. But if TVS says it's not ectopic, acute surgical abdomen, you will always open. Then it will be appendix, or torsion, something like that. Got it? So TVS is not decision making when patient is having acute abdomen. Okay? You have to do surgery in any way. However, if she is not stable, you do laparotomy, and if stable, you do laparoscopy. That's it. Okay. So if it is, ectopic tubal, and patient, you have discussed with patient all options, and she fulfilled the criteria of expectant management. Means no mild pain, β-hCG values less or equal than 1,000, you will offer. Gestational sac less than 35 mm with this, and no FCA, no pain. You will offer expectant. And if it is less than 1,500, you will consider me expectant. Okay. So this is case of expectant management. So a patient who is fulfilling the criteria of expectant management, you will do her β-hCG on day 2, 4, and 7. And decision making will be the day 4 and 7, not day 2 and 4. Okay. So day 4, β-hCG, they have given you β-hCG 1,000 on day 2, 200, 100 day 1, day 2, and day 7 it is 300. So your first value will be the 200, which you will pick for calculation, and you will multiply it with 0.85. Okay. And then you will cross check it with the day 7 value. Okay. And if it is dropping more than 15%, you will continue it on expectant management, repeat weekly her β-hCG until it will be less than 20, which we consider negative. However, no drop, same rise from previous value, or she developed pain, then, involve senior, do again her ultrasound and decide further as per the decision. Now, a patient who is having confirmed tubal ectopic pregnancy, she is clinically stable, pain-free, means no surgery needed here. If any ectopic, whatever is β-hCG, whatever is SAC, if she's having severe pain or, symptomatic, then we will do the surgery, obviously. But if she is pain-free, clinically stable, SAC less than 35 mm, no fetal heartbeat on TVS, she are able to return to follow-up. If yes, then you will check her β-hCG. If no, then there and then do surgery. Yes, she can come on follow-up, and her β-hCG is less or equal to 1000 of her expectant. If it is less than 1500, consider expectant. If it is 1500 or more, and then by default she is not suitable for expectant. Any patient who is having 1500 international units β-hCG, expectant is straightforward out. It should be less than 1500. Okay. So we said, like, after 1000 we can consider expectant. So after 1000, what we will offer? We will offer MRCOG. Okay. So next. So this is the quick overview of ectopic pregnancy. Skip miscarriages right now. I want to complete miscarriages first. Then I will come on the management of miscarriages. Okay. So this is our Green-top Guideline 2016, and we already know that all type of ectopic we diagnose on TVS, and but we can see adnexal mass separate from the ovary, right? And then we will check β-hCG just for management purpose, not for diagnosis purpose. So when we will manage her as an expectant care, we will offer first line if serum β-hCG is equal and less than 1000. If it is more than 1000 but less than 1500, we will consider, provided that she is pain-free, stable, and her SAC mass is less than 35. And she will come on follow-up on day 2, 4, and 7. If β-hCG dropping 15% each time, we will keep her on follow-up weekly β-hCG until it will be less than 20. If beta-hCG fails to drop less than 15% or plateau or rise, then we will involve senior and we will further again do her ultrasound. Maybe she can develop FC positive, right? And we will further manage as per the decision. For MRCOG, beta-hCG more than 1000 but less than 1500, this is perfect, ideal. However, if it is more than or equal to 15,000 and less than 5,000, less than 5,000, not 5,000, then she can choose any, MRCOG or surgical. Okay. So I am giving you a brainstorming question here. Just let me to finish my tea so I can feel better. Okay. टी की दही बन गई है ठंडी का. Okay. So let me know. Just imagine a patient who is having only one tube left. One tube left. Right? And because second tube is, closed because of some surgery or previous ectopic, you have done salpingectomy. Now she is coming with again another ectopic. And ectopic is in, earlier it was right, now ectopic is in left. Right, we have already, lost. We left with only left, and left is again having ectopic. Her β-hCG is 1600. Sac size is, let me 34. So what we should do? She fulfill the criteria of both surgical and medical. What is ideal in her case? And she want to, preserve her fertility. So many says metho and many says surgical. And ask another question. The same patient, you have, send her home and she is on metho follow-up. And during follow-up, obviously on follow-up, patient can suddenly, develop rupture. She ruptured her only viable tube. And if it is ruptured, so you will left with no choice of doing except salpingectomy, because rupture treatment is only do salpingectomy. Okay, so and if you have did her elective salpingotomy, and there and then her issue resolved. So what is more good in her case? Or what is more predictable outcome in her case? So predictable outcome is never metho. Metho situation can go in anywhere. But surgery is in our hand. It is predictable, and that patient remaining left tube is very precious. We don't want any surprise, right? However, a patient is low risk and understand the risk of metho and highly motivated and refusing surgery, so metho is okay then. Okay. And if pain and fetal heart rate present, β-hCG 5000, she can't come on follow-up, then do surgery. Okay, so we have covered ectopic tubal. And now summarize all type of β-hCGs here with this slide. You can take your time because if you will keep revising volatile points, it will actually make your better memory circuits and less chances you will forget in your exam. Okay, so I request all of you to take screenshot of this slide, save it in your mobile, make your WhatsApp group, and name it like that, volatile slides, which you want to revise frequently. You don't have to open the lectures and notes every time. I used to say that. I used to do that, and before my exam, there were approximately 200 slides or screenshots saved in my WhatsApp. And before Monday exam, I just revised these two volatile things because I know I used to forget them, and it was super easy for me to revise by that day. Okay. So see, here we are 63% rising. We are doing scan after 1 week, 50% dropping. We are doing UPT at 14 days. But if on intrauterine pregnancy route, patient is having second β-hCG more than 1500, we are not waiting for 7 days. We are doing earlier, right? Okay. Then coming towards the bleeding patient, low risk and bleeding and no pain, we will just advise to repeat her β-hCG after 7 days. That's it. Miscarriage confirmed. Whether we managed expectant, medical or surgical, in every situation we will repeat her UBT at 3 weeks. Only in expectant we call her after 2 weeks. If she has not actually started bleeding, then we will do her TBS. Otherwise, she has started to bleed, then she will repeat her β-hCG, urine β-hCG in her home at 3 weeks. Salpingectomy, UPT at 3 weeks. Salpingotomy, we will do her serum β-hCG weekly. Okay. if it is dropping on day 4 and 7 more than 15%. No. In solpingectomy, we will keep doing her β-hCG weekly. With molar, you will actually register more β-hCG follow-ups. So I will give you a grand flashcard where every timeline of β-hCG and method of β-hCG, whether serum or urine, will be mentioned. So no worries. So here I have compiled 2 things: expectant management when patient location is not sure, and expectant management when miscarriage is confirmed. Both are different. Do not mix them. So we have covered a lot, but still we are left with management of miscarriages. Okay. So now we will do how we should. So before this, we start management of miscarriages. One thing is that remember their mechanism of action, the drugs which were used in termination process. One is mifepristone. Mifepristone is a drug that blocks a hormone called progesterone, right? Because of this, we say that this is a progesterone antagonist. Misoprostol is a synthetic prostaglandin E1 analog, and prostin E2 is prostaglandin E2 analog. Okay. So prostin E2 stimulate the myometrium of the gravid uterus to contract in a manner that is similar to the contraction seen in the term uterus. And prostaglandin E1 or misoprostol more effectively work on poor bishop or on cervical connective tissue. And prostaglandin E2 more efficiently work on myometrial tissue, right? Mifepristone is a progesterone antagonist. What about the syntocinon? We don't use syntocinon in early pregnancies because the receptors has not been developed so far. So no use of synto in early pregnancy terminations. We used only these 3 drugs, not synto or oxytocin. Okay. So like a patient who is actually having confirmed miscarriage, so we will see whether she is high risk or not, whether she is stable or not. If she is high risk or having stability issues, we always do her surgical management, rather immediate surgical management. Okay. If patient is stable and she is not high risk, then we will discuss her to pick the option of expectant management or medical management or surgical management. So if patient has opted this expectant management, in expectant management, remember the points which I am going to highlight. Expectant is also first line, depending patient want it, and medical is also first line, depending patient on want this. So we will discuss that. We will only discuss with her that you can opt this, you can opt this, and you can opt surgical as well. Okay. However, we have discussed patient that in expectant management, it will take 2 weeks and it will be the follow-up time, and she is not going to opt it, then obviously we will discuss with her medical management. Okay. So till 13 weeks or in first trimester, we can manage miscarriages as expectant. But if patient is high risk, then we will not give her this choice. And we already know that we will call her to come after 7 or 14 days or 1 to 2 weeks. If bleeding and pain actually resolve, it's okay. She will repeat her urine pregnancy test at 3 weeks. If not resolved, she will obviously come at 1 or 2 weeks and we will do her ultrasound. Okay. This is important. And many questions has been repeated from this area. Medical management, if patient opted, we give her mifepristone. If it is, a confirmed miscarriage and it's not incomplete, because in incomplete, we never give mifepristone. Remember this. They will give you a lot of options that OC is open, few products of consumption has been out. She want medical management, what you will give. and every option will start with mifepristone, and only option E or maybe option Q will be with this, only with misoprostol. So opt only misoprostol because this is the incomplete miscarriage. Forget about the doses right now. I will suggest you do the doses near your exam. When you will do IUFD, GTG, induction GTG, and first and second trimester doses. Then revise all these doses together because they frequently actually mix and interchange. So why to put effort right now? So you have choice. Either you can remember them near your exam, or you can remember them now and keep revising it. But it's not very high yield exam topic. So in my opinion, remember them near your exam. And after this, keep, revising them. So it will be a wise practice. But anyway, if patient is opting medical management, mifepristone dose is 200 milligram. And after this, 24 till 48 hour, she will start misoprostol. But what is the best time? Best time is neither 24, neither 48 hour. It is 36 hour after taking mifepristone. You will give her misoprostol 800 microgram, any route, vaginal, oral, sublingual. Okay, vaginal, oral, sublingual, and then but not rectal. And here are also vaginal, oral, sublingual. Okay, so remember the route as well. And medical management patient has taken drugs as well, so you will give her antiemetics as well with this, and she will repeat her UPT at 3 weeks. So it's very easy. In every type of miscarriage, she will repeat her UPT at 3 weeks. That's it. And about the manual vacuum aspiration. Manual vacuum aspiration is type of surgical miscarriage, but it's not done for high risk patient. Okay, we do it in low risk patients who want a surgical management and cannot come on multiple follow-ups like medical and expectant, right? And this guideline do not provide much detail on MVA selection criteria. We will do it separately from this TOG article. However, another option is EVA, evacuation done under OT under GA. And this is the only method which we used in those patients who are having septic miscarriage, are high risk, are having hemodynamic instability. Okay, and sepsis is not contraindication of evacuation. Rather, it is actually done on urgent basis. Okay. Next, whether you have done MVA or EVA, any type of surgical miscarriage, you will give her antibiotics as well. In abortion care guideline, you will give antibiotics for 3 days. And in miscarriage guideline, if patient actually coming with miscarriage, you will give her antibiotics, which is doxycycline, 200 milligram BD for 7 days, starting within 2 hours of the procedure. Okay, and 7 days better than 3 days. NTD, this guideline says you have to give, but abortion care guideline says you don't have to give before 12 weeks. So here we have seen discrepancy. So what about the MVA? NICE does not give any true cutoff values for expectant medical managements. However, TOG says that MVA is better if we do at 10 week of at or before 10 weeks, or patient is having retained tissue less than 5 centimeter. Okay, and surgical section evacuation, which we do in under GA and OT, we can do it up to 14 weeks, and even up to 16 weeks. It's possible. Okay, and usually UPT is not required after surgical miscarriage if patient is not having any symptoms of excessive nausea, vomiting, or any evidence of molar or atypical features. Standard UPT done at 3 weeks, like in medical or in expectant, is not like for surgical. Okay. Next is few references which I have just covered. Like if patient is opting expectant management and pregnancy is less than 6 weeks and having only bleeding but no pain, and who have no risk factors such as previous ectopic, so she will do her EPT at 7 or 10 days and will come urgently if having atypical features. So remember these figures as well. If endometrial thickness is 15 or more than 15 and having bleeding as well, then this is an incomplete miscarriage. One figure is also important. If RPOC size is 30 mm, so better to do surgical management. However, you can do medical as well, but doing surgical management is very, successful thing. Its reference is not nice, neither GTG. The other Irish guideline here says that if RPOC size is big, then if you will leave her on her own or on medical management, she will bleed more and more risk of anemia or more risk of infection or Asherman syndrome. So here, if you have to pick one, then pick surgical management. Okay. So this is about MVA talk article. They said MVA we can then do only in low risk and stable patients, which is PARAS, well motivated, CRL less than 25, and RPOC is less than 5 centimeter, and not having any infection or sepsis. If her gestational age is 10 weeks or more, having panic attacks, cervical stenosis, fibroid, 12-week size or more, then don't do this. Okay. Then you have to remember the complication of medical and surgical abortion. And I will suggest you in exam, every time they just ask about the risk of perforation in surgical miscarriage. So it is 1 into 4 per 1,000. Okay, this is your recall. And if you can see, infection risk is same in surgical and in medical. 1%, less than 100, 1% in both. The proximate risk is more or less same, but additional risk in surgical miscarriages of uterine perforation or cervical injury. These two risks are more in surgical abortion. However, in medical abortion, the chances of being unsuccessful are more, like 1 or 2 in 100. Here, only 1 in 1,000. So surgical abortion is more predictable and more successful. So now I will quickly just cover a latest guideline of abortion care. I have not seen any single question so far from this guidelines, neither in the recent paper. But for the sake of compilation, I will just complete it. That for abortion, patient actually, if her gestational age is less than 24, like not viable, and she can opt termination. We will discuss abortion laws as well. But right now, if she fulfill the criteria of social termination or any like termination because of her health conditions or fetal abnormalities, so self-referral to abortion services is permitted, and assessment ideally should be done within 1 week of request, and abortion should be started within 1 week of assessment. Do not impose compulsory counseling. Do not impose compulsory reflection period. Personal beliefs must not delay access. Like if some Jews and Muslims don't perform abortions. So if you are religious beliefs do not permit it, do not delay the process. Just refer her someone else who can conduct it. Okay. Personal beliefs must not delay the access. Telephone or video assessment may be offered. And rest, counsel her that abortion is not associated with increased risk of infertility, breast cancer, and mental health problem. Okay, discuss with her good contraceptions and explain her about all options, medical, surgical. She can opt any method which is suitable for her, and she can fulfill that prerequisites. However, you will also educate her about the warning symptoms or red flags. NTD prophylaxis, this guideline says do not offer NTD for medical or surgical abortion. However, if you are performing it after or 12 weeks, then you will give NTD. Okay. For medical abortion or in medical miscarriages, we usually don't give antibiotics. We give antibiotics only in surgical or abortion or surgical miscarriage, which is doxycycline. Do not routinely combine metro with another broad spectrum antibiotic for surgical abortion without infection. Okay. BT prophylaxis for women requiring pharmacological thromboprophylaxis, consider heparin for at least 7 days after abortion if they are having, if they having certain risk factor for thromboprophylaxis. For women at high risk of BT, consider starting heparin before abortion, consider a longer post-abortion course. And one question has been coming from this point, that if patient require, because we just know about the delivery things, like after delivery we have to start with heparin and warfarin, so many things. But in this guideline they have added, if abortion before 24 weeks happened and patient needs thromboprophylaxis, you can start it before the abortion. Do not delay it, because she will bleed heavily, because you are not going to giving her any regional anesthesia for this. However, if you are giving regional anesthesia, then situation will be different. We will discuss it later. Choice of method will be medical, surgical, depend on her, availability, depend on availability and on her personal decision. And third one, she is eligible or not. Okay. Then explain her about possible risk of ectopic, need for follow-up, need for urgent review. If ectopic symptoms occur, provide 24-hour emergency contact number. If you are going to use surgical methods, then prime the cervix. Anesthesia, she can opt local, conscious sedation, deep sedation. And for conscious sedation, use IV rather than oral sedation. And for general anesthesia, if you opted, consider propofol with a short-acting opioid. And this is the recap. We have done this already. And so NTD, so far, NTD, the current confusion is that because the NICE abortion care guideline is more recent, so better not to give before 12 weeks, whether it is ectopic, whether it is molar, whether it is surgical miscarriage. Do not give NTD before 12 weeks. Any query? I'm waiting for your questions now. Mm-hmm. Okay, I think I missed one slide about ectopic pregnancy. I told you I will cover it later. So this is cesarean scar ectopic pregnancy. And for this you have to read this algorithm. So there are two types of ectopic pregnancies, cesarean scar ectopic. One is type 1 and one is type 2. Type 1 is endogenic cesarean scar ectopic pregnancy. Like in this type of pregnancy grows inside the uterus. Okay. And type 2, in which pregnancy grows towards the bladder. We say that it's an exogenic cesarean scar ectopic pregnancy, right? So type 1, in which pregnancy grows inside the uterus. So if something is inside the uterus, we can do suction evacuation. If myometrial thickness is adequate, we can do it under ultrasound guidance, because this is high risk and under vision is recommended. And for hemorrhage control, we can add balloon tamponade, cervical sutures, uterine artery embolization. And if it is growing towards the bladder, then obviously we can't do suction evacuation because nothing is inside the uterus. So we have choices of doing laparoscopic excision or open excision, and then we have to repair the scar where possible. This approach removes the pregnancy and repairs the scar defect. Okay, so this is about the cesarean scar ectopic pregnancy. And in cesarean scar, if patient is hemodynamically unstable or cesarean scar is ruptured, then you have to do emergency surgery, right? Patient is obviously unstable, so you have to do laparotomy. And in some cases, you have to do hysterectomy as well. Okay. However, if patient is hemodynamically stable, then you will assess that what is the gestational age, what is the β-hCG value, what is the type of cesarean scar ectopic pregnancy, type 1 or type 2, or endogenic or exogenic. And accordingly, you will check the patient fertility wishes and availability of, interventional radiology as well in your center. So by that way, you will plan. Okay. So, like if I ask you, in among cesarean ectopic pregnancies, type 1 is more dangerous or type 2? So type 2 is more dangerous because it is growing towards the bladder. Definitely scar will rupture, then it will grow towards bladder. So the more dangerous type is type 2. Okay, that's why in cesarean ectopic pregnancy, expectant management is less, not favorable. And if we have to do medical management, then we have to see a lot of, things. Okay. Let's assume if pregnancy is viable and it is cesarean scar ectopic pregnancy and patient refused termination, then what will be the future of this pregnancy? Then it will be morbid adherent placenta pregnancy spectrum. Okay, you have seen placenta accretas, then it will be like that. And yes, so this is now I will say compilation of all type of non-tubal ectopic pregnancies like interstitial or cardiac. I told you 90% we do surgery, so here we will do surgery. Cervical ectopic, if early less than 9 weeks and 10 less than 10,000 β-hCG, so we can give metho, and otherwise we have to do surgery. Cesarean scar type 1 inside the uterus, we can do suction evacuation or local metho may be considered in selected stable cases. And if it is type 2, then laparoscopic excision and scar repair, ovarian ectopic, laparoscopic enucleation, vag resection if required, primary treatment. I am just mentioning the primary treatment of each type of non-tubal. Okay. If it is abdominal ectopic, laparoscopic removal, and if it is advanced, then are more than 20 weeks, then you have to do laparotomy, and you have to leave the placenta inside too if it is densely adherent. Okay, and if it is heterotropic pregnancy, surgical removal is preferred. After this, local potassium chloride into ectopic sac if fetal cardiac activity present. However, avoid systemic metho because this is heterotropic and if intrauterine pregnancy is viable. Okay, this has been tested a lot of time in question. So heterotropic pregnancy ideally surgical management. If you can't do surgery and surgery is high risk, then you will see that like you can do like you can into the sac you can inject potassium chloride or hyperglycemic fluid. Okay, never ever systemic metho if patient is having live viable intrauterine pregnancy. Okay, so this in the table and it is very important. Let me to explain it. See, I have added here non-tubal cervical. So how you will diagnose it? Cervix will be barrel shaped and sac below the internal os, and sliding sign will be negative because it is adherent with. But this is not a RPOC which will move. It is pregnancy which is adherent in cervical canal. It will not move. Cervical sign will be negative. And in cervical early, we can add metho as well. If β-hCG is less than 10,000 or less than 9 weeks, or CRL is less than 10 weeks. So gestational age less than 9, CRL less than 10, and β-hCG less than 10,000. Only in this situation we will manage her on metho. Cesarean scar, I told you already about this. And the interstitial, it's mean that uterus is empty, but myometrial thickness is around the sac is less than 5 mm with positive interstitial sign. First line always BTVS, and interstitial, if criteria met, we can consider medical, otherwise surgical. Carnual, myometrium covered, and this is very dangerous. In cornual ectopic pregnancies, patient can come at 12 and 14 weeks as well. And we have to do surgery only for this. Okay, ovarian surgery is first line, and metho only if surgery is high risk. And in ovarian ectopic, sliding sign is also negative, like the cervical ectopic. Yaad rakhiyega. Okay. Heterotropic. In heterotropic, do not rely on β-hCG because of intrauterine pregnancy. β-hCG will be high, and still it will be ectopic. Okay. And regarding abdominal, if it is less than 20, you can do lepro. If it is more than 20 weeks, then laparotomy is better. However, if TVS in any kind of ectopic is not conclusive, second line investigation is MRI. Okay, so we have covered now all non-tubal as well. Thank you for your time and patience. Now, in coming days, you will practice a lot of questions, and how much good you are in your theory. If you are not practicing questions, then you are at risk. Okay. And how to follow the course, another thing. I will suggest you first listen my lecture, then read the guideline. Because if you will read the guideline first and then attend my lecture, then you have to read very unnecessary things and it will take your whole day. So if you are reading your GTG and your documents after listening me, then you can easily actually understand. Like for example, if after my miscarriage and ectopic lecture, if you will read nice and TOG articles and GTGs, you can better understand. You already know what is the what are the basic definitions and how questions are coming up. So number one, always listen my lecture first, then read the original guideline, and then practice the questions. Okay. About the groups which we are, like, which are part of our course, there are actually, how should I write? So those who are joining us now, for them, there are a Q bank, okay, channel. Here we will discuss topic-wise questions. Like if today we have to do hyperemesis or pregnancy, nausea, vomiting, Green-top guideline. So we will do topic-wise questions in that Telegram group, right? And another group is only for summaries. Like tomorrow we are going to read GTG of hyperemesis or nausea, vomiting in pregnancy. So in this group, you will read the summary of this guideline. Okay. And it will be very, high yield and only exam important points you can read here. So if you have not actually attended the lecture as well, summary can compensate you. After reading the summary, you can easily attempt your topic-wise questions. Okay. So number one group, QBank. Here you are solving topic-wise questions. Number two is summary group. Here you are reading each module, each topic summary. And number three will be book-wise group. Here you will see a lot of folder like mastering folder, Rekha, right? Amanda Jones. There will be 10 plus folders in this group. And here we will cover each book. Like first we will cover like Amanda Jones, then Rekha, then Sir Andrew, Blue and Old. So in these three Telegram groups, you will do different activities. One group is for topic-wise questions. One group is for summaries. One group is for for books. So only three groups will be on Telegram. Rest everything will be on the website. Website you will attend the lecture. If you have missed the live session, you will watch the recordings. You will attend the mock, and more importantly, you can read your recalls of your MRCOG Part 2 right from 2018 till 2026. And why I am giving you access of this recall book? Why I'm not actually adding it only my fast track? Because many people just don't share the recalls because they believe they will cover the recalls as well. So who will buy their fast track? So my aim is not about the business, because right from the beginning of your preparation, you should be actually aware of your exam recall. So accordingly, you can actually modify your preparation. You can highlight those points which have been tested in exam, and you can ignore those points which are not very high yield. Okay, so you will, whenever you have time, try to read your papers as well. Each question you will see will be properly written, and there will be the reference as well. Okay, so this is all about the course and about my study method. If anyone among you want to join our course, can actually contact on provided number. Okay. So thank you very much. This is all what I want to say. Any query at your end? No query. Okay. Thank you.